So good morning, everybody, and thank you very much for inviting me to speak here today. I would like to start by acknowledging the team on behalf. I'm presenting our experience with HIV testing in the city of Vancouver. Just a little bit of a background on the city of Vancouver. I'm sure you've heard a great deal about it in the last 3 days, but it's your host city. It's got a population of about 600,000. It has the highest rate of new HIV diagnoses in British Columbia at around 19 diagnoses per 100,000. And we in Vancouver have a highly concentrated epidemic with somewhere between 65 and 72% of new diagnoses occurring among men who have sex with men. The HIV testing context in Vancouver is very interesting. We have a good availability of low-threshold HIV testing facilities, both outreach and in community clinics, probably one of the best in the province, or definitely the best in the province. We have universal health care with free HIV testing for everyone, and upon diagnosis, free treatment for everyone. However, in British Columbia, and in fact in Canada, we've had no significant change in HIV testing policies over the past 20 years. Unlike the United States, the United Kingdom, and France, and some other countries, we actually have no national or provincial recommendation for routine HIV testing anywhere in Canada. To some extent, we didn't even ask the question, is what we're doing good enough? Until 2009, when the Stop HIV and AIDS pilot, a provincially funded $48 million pilot, compelled us to do better with early diagnosis and treatment of HIV. And when we asked the question in Vancouver, I think we're a little bit surprised, perhaps we're a little bit smug to find that 60%, that in Vancouver, where we thought we were doing really well, 60% of patients are diagnosed after they should be on treatment. Around 50% are diagnosed with a CD4 count of less than 350, and a consistent fifth are diagnosed with advanced HIV disease. So because we were given this task by the Stop HIV/AIDS pilot to do better, our real question was how to do better. And again, at the beginning, what we did is we did more of the same. So we did more community outreach, we did more testing, and that had some effect, but not really a visible population effect. So we did realize we needed to do something else. And as I mentioned, we had no standard of care by the equivalent of CDC or the Health Protection Agency, so we stole a recommendation from you and adapted it to our own setting. But because it wasn't really a national recommendation, we couldn't go out there and say, please implement the standard of practice. So what we needed to do is to reach out to the medical community, and particularly to the medical community who are not thinking about HIV testing. The rationale for that is that 8,000 people today will see a family doctor in the city of Vancouver. If we're going to make a population level change, we actually need to speak to those physicians who would never come to a conference like this. And when we reached out to physicians, the first thing we needed to do is tell the story, your story, the story that underlies the CDC recommendations or the HPA recommendations, which is that early diagnosis is the goal. Having spoken to many hundreds of physicians, I can tell you that that is not in the consciousness of the public. The enormous changes that treatment has made to HIV is something that is familiar to us, but it really isn't in the front and center in the minds of people who don't look after HIV patients. And when you convince individuals or clinicians that early diagnosis is the goal because treatment has such an individual and a population level, then showing data that we're not doing it and that we're missing opportunities in practices like yours to diagnose people early, and that what those missed opportunities look like in terms of case stories so that clinicians can actually relate to them. They can actually internalize that I would have missed that diagnosis too, were really compelling conversations and presentations to family docs. And what was interesting is when we started the pilot, we thought that we would need to create incentives for clinicians to participate in a routine testing pilot. Interestingly enough, once the rationale becomes clear to them, that's all the incentives they really needed. They needed support, but not incentives. Opinion leaders, both in and outside of the HIV treatment and prevention community, were very important, both within the community and in the care providing community. And of course, enabling policies, which you're all aware of, which is simplifying the consent process. And the one I'm going to spend a little bit time on is what we needed to do to acknowledge the magnitude of the practice change we're asking these individuals to make. And one of the things we needed to do is actually untrained physicians. We trained physicians really, really well on risk assessment. They believe in it, they think it's the right thing to do. So we needed to demonstrate both through data, through stories, and through logic that risk assessment is actually a fairly poor clinical tool for making a testing decision. In terms of logic, risk assessment gives you an answer in a continuous variable. People are somewhere on a scale of 0 to 1. Yet the decision to decide, the decision to test is actually a binary variable, yes or no. So what is the right number that switches you from yes to no? We also needed to show with data that epidemiology changes. Therefore, if you are testing based on risk profile that was true 5 years ago, you're actually maybe testing the wrong people in British Columbia. And then to demonstrate that even when we're aware of the risk, we're not necessarily testing people with data like the fact that less than 25% of people in British Columbia with a diagnosis of a sexually transmitted infection have an HIV test within 3 months of that diagnosis. Just to really bring the data to physicians so that they understand that even with people whose risks are right in front of their faces, for some reason we don't test. And I think one of the most common reasons is that many of us assume that if your risk is that clear, you've probably sought testing somewhere else. Other ways to acknowledge the magnitude of the change for us was providing supports to physicians who are unfamiliar with HIV linkage and care. In British Columbia, HIV is reportable to public health, and through that mechanism we were able to provide public health support with disclosing the diagnosis and linking patients to care to physicians who may have never done that before. That actually ranged from a phone call from a public health nurse to a public health nurse sitting with you, with your patient, while you're disclosing an HIV diagnosis for the first time. The most extreme version of the support with follow-up was actually a delegate follow-up process, which was a very important follow-up process for testing in settings such as emergency departments or walk-in clinics where the clinician may or may not see the patient again. And it really enabled the delegate follow-up process basically meant that the public health nurse would do the entire follow-up on your behalf. And that enabled physicians to test individuals whom they may or may not be in a position to follow up. And then simply support with making the change, such as reminders, posters, EMR prompts. And an important part was feedback on the outcomes. And for family physicians, that took the form of a report card that you can increase your routine HIV testing. And for departments and hospitals, it actually involved case rounds about what those new diagnoses actually looked like. So we had two simultaneous approaches of expanding routine HIV testing. We launched a comprehensive hospital-based initiative in all 3 acute care hospitals in Vancouver, as well as a very broad educational initiative for family physicians who participated in 1 to 3 hour workshops. Well over 500 physicians participated thus far. And our findings are probably not going to be surprising to you. We found that routine HIV testing in hospital is feasible. Over the course of about 3 years, HIV testing in the 3 acute care hospitals increased from less than 500 a month to 2,000 to 2,500 tests a month, and that remained steady. Also in family practice, we were able to demonstrate that after physicians participated in an educational session, they were able to increase their HIV testing rate. And to give you a sense of the magnitude of the impact, throughout the city of Vancouver, prior to the initiative, every 6 months about 38,000 HIV tests were done. In the last 6 months of the initiative, 73,000 tests were done. So basically, at a population level, we increased HIV testing by 90%. What we also found, which is again probably not going to be surprising to you, is that routine offer of HIV test as part of medical care was highly acceptable to patients. And if I can figure out the pointer, yes I can. In fact, 94% of patients who were offered that test in medical admission units accepted that test. And again, the challenge remained, as we knew it would, with increasing our offer rate. So really, we confirmed what the Health Protection Agency pilots found, that the barrier is really the offer by the physician rather than the acceptance of the patient. This was a very important finding for us because we had a very short pilot to do, and therefore we kind of did everything at once. And one of the things we did was a social marketing campaign, which was a very pretty social marketing campaign, but this number actually told us that we probably didn't need to do that. In other words, the patients were already perfectly fine. We also found that in our city, routine HIV testing was above the cost-effectiveness threshold that is generally quoted. We don't have cost-effectiveness thresholds for Canada, but we did find that our diagnostic yield was 4 per 1,000 in hospitals and about 2 per 1,000 in primary care and outpatient emergency departments. But what we really found interesting was the type of patients who were diagnosed, especially in hospital. Some things we expected and some things we didn't. So for example, we did expect the risk profile to be slightly different. We did find that a smaller proportion of hospital diagnosed patients were belong to the traditional risk groups, and in our community that's men who have sex with men. We also found that we had a higher rate of advanced disease in hospital, 35% versus 12% in the rest of the population. Again, not surprising. We're diagnosing individuals who are sick, who are coming to hospital sick. But one of the things we didn't expect is that we had a higher rate of diagnosis in the acute phase of infection. And this actually occurred in the outpatients emergency departments, and those data are actually continuing. And so what we learned was that yes, we are diagnosing more late infections in hospitals, so we're diagnosing the people who've been missed. But it's also it is an opportunity for diagnosis for first-time testers or testers with no identified risks. But it's also an opportunity for diagnosis for regular testers and those with clear risks. So a little bit about the type of patients we expected, such as this 51-year-old married man who has been seen in hospital multiple times, and he's a heterosexual man with no clear risks, and eventually tested on routine testing and found to have advanced HIV disease with a CD4 count of 10. What we didn't so much expect was this type of patient, the 31-year-old male who presents to the emergency department with abdominal pain, is tested routinely, found to have acute HIV, and in fact his last test was 6 weeks prior. So really what we learned is that, going back a little bit, is that the diagnoses in routine testing or through routine testing reaches a different but overlapping population with risk-based testing. Now, I do want to say that as part of this initiative, we didn't just do routine testing. We also strengthened significantly our outreach programs and our routine testing in high prevalence settings such as mental health settings and methadone clinics. So the question did remain for us, what is the idea? All of these had good diagnostic yields, good uptake, and worked very well. So the question for us was, what is the optimum mix in a city like Vancouver with a highly concentrated epidemic? And we worked with the Impact HIV modeling group to create a model that determined the best allocation of resources among existing HIV testing programs in Vancouver. And the modeling group, some of whom are here, created a model that considered inputs from tests, such as cost of test, and incorporated the cascade of care. And again, the goal of the model was to minimize HIV incidence over 5 years. And I'm just going to focus on this picture that looks at what would be the optimum allocation of resources with our current data in the city of Vancouver, assuming a cost ratio of tests between routine and risk-based tests, which are realistic probably at around 3 to 7 to 1, depending on the intensity of the risk-based test. Again, remember, we were trying to minimize incidence, so the optimum allocation of resources is the ones with the shortest bars, and the bars represent different percentages of your overall resources that you put into routine testing in Vancouver. And we find that the shortest bars with the most realistic cost ratio estimates would be somewhere between 20 and 60%. So how was this model useful for us? Well, actually, it was useful in a number of ways. It confirmed the counterintuitive notion that even in a very concentrated epidemic, routine HIV testing makes a significant contribution to early diagnosis that cannot simply be replaced by more targeted testing. This model could actually be used by other regions to guide program planning. But as Brian Williams taught me on Saturday, models won't necessarily give you the answer, but they'll always sharpen your question. And what we really learned is that when designing our testing programs, we were actually asking the wrong question. We were asking who's getting HIV, which meant that we only used one piece of data at risk to design our testing programs. And what we should really be asking is, how do people who have HIV interact with the healthcare system? And that way we're allowed to use, that enables us to use all of our data. Can I say one last thing? Okay, so this pilot program was actually we were fortunate that the pilot program did become a provincial program in 2013 for the province of British Columbia, which is 4.6 million people. And so one of the things we needed to do is a new HIV testing recommendation. And what we did is gathered a group of family physicians to put what we learned into words that mean something to them in their clinical practice. And this is what they came up with. That the Provincial Health Officer of British Columbia recommends that healthcare providers know the HIV status of all their patients under their care. And specifically, we recommend that providers offer a test routinely every 5 years to all patients aged 18 to 70. Clinician told us we need to add a frequency, even if we don't know what the optimum frequency is. If you don't add a frequency, it's not practical to implement. Highlight higher burden of illness population for more frequent testing. Don't forget the elderly, and remember that HIV test is part of the differential whenever somebody presents with an illness severe enough to require diagnostic testing. And then finished with the risk groups that we have tested all along. And these guidelines are going to be published on May the 1st, and thereby British Columbia becomes the first Canadian province to join other jurisdictions with a routine HIV testing recommendation. Thank you for your time.